I'm Dr. Marc Cohen, Emeritus Professor of Medicine at the Mayo Clinic and Adjunct Professor of Medicine at National Jewish Health in Denver, Colorado. And I couldn't be more pleased to join you again for the Rheumatology Highlights Report. My section is entitled Advances in Efficacy and Safety of the TNF inhibitors. Again, this year there have been a number of advances, I think, in the use of TNF inhibitors, and I am really happy to be able to share my opinions about that. I have no disclosures to report to you, which is always safe, and I think we can get right into data. My comments are based on multiple abstracts from the recent international meeting, as well as discussions with fellow rheumatologists. I think one of the more interesting concepts presented at the meeting and discussed this year is the concept of induction and maintenance, particularly in early rheumatoid arthritis. This is obviously a concept borrowed from our oncology brethren, and it does turn the previous paradigms, at least to some degree, on their head, because here we're not using the cheap drugs, if you would, or the disease-modifying traditional anti-rheumatic drugs like methotrexate first. In this concept, we're using very aggressive treatments very early in the disease to see if we can induce at least a clinical remission, and then change the medications for maintenance or ongoing treatment. A fascinating concept and one that deserves a great deal of discussion. To sort of demonstrate the concept, I'd like to discuss three separate trials with a fourth in the background as an additional study you might want to examine yourselves. In conclusion, before I show you the data, there is some early evidence that by using aggressive therapy very early in the RA disease course, that biologics may not be necessary continuously, or at least as part of maintenance therapy. I think this is fascinating. This was really presented with emphasis by Paul Emery's group in a abstract numbered Thursday 0251B. I'm not sure why, but this is there were two number 251s on Thursday. And he, in fact, entitled this Maintenance of Biologic-Free Disease Control in Early Rheumatoid Arthritis Patients After Induction of Low Disease Activity with Adalimumab plus Methotrexate. So 207 patients ultimately in their phase 1 of the trial, 466 original early RA patients were methotrexate naive and given adalimumab plus methotrexate, and as I mentioned, 44% achieved a DAS less than 3.2 by week 26. In a very interesting design, these patients were then randomized to placebo plus methotrexate or adalimumab plus methotrexate and followed all the way through week 78. Very interestingly, there weren't a great deal of differences between the two groups at 2 years. 64.3% of patients achieved remission, and this, I think, is at least initial evidence that the methotrexate alone might be as good as the combination of methotrexate and a biologic in some very early patients. In other words, we don't need necessarily to continue the biologic if, in fact, it is used early and aggressively in an induction protocol. Usual doses of meds were used, and I think it's really a very interesting phase 2 to a large Optima trial. In another study, actually, the Emory group looked at the concept of induction and remission in early rheumatoid arthritis, presenting some initial data from their study regarding patients randomized to infliximab at 3 mg per kg with the dose increased if the patients did not achieve remission, versus high-dose methylprednisolone, 250 milligrams, and then spread out over a couple of weeks. And again, at week 26, I think fascinatingly, the clinical remission was achieved in 32% of the infliximab group and 34% of the corticosteroid group. So again, I think the conclusion from this ongoing trial is that the early treatment may in fact include a biologic and methotrexate, or perhaps even high-dose corticosteroids and methotrexate. A very interesting trial, which of course harkens us back to the COBRA data back in the early 90s. Very interesting strategy, and it will be interesting to see what happens as that study progresses, particularly with regards to erosions and radiographic changes. It'll be fascinating to see if the high-dose corticosteroid group can even compare to the methotrexate plus biologic group. In addition, the next slide demonstrates yet another group examining induction remission, this from the terrifying BEST trial. I think here you need to go back and remember that this trial had 4 arms originally, one of which included patients treated with initial methotrexate high dose and infliximab out of the gate. So they received the combination very early, and then they were followed, and this was compared to the other clinical groups, and it turned out 120 patients were treated with the initial combination of methotrexate and infliximab, and yet 109 patients used that combination after failing more traditional DMARDs. So you've got more than 200 patients who received not necessarily an induction, but received the combination, some as an induction, but some later. And this time, there was a difference between the groups. In fact, the patients who were treated very early with the combination had higher success rates in achieving remission than adding the combination later. So again, this is one of those conclusions teased out of the rather complicated BEST trial, and it will be very interesting as we continue to follow those patients. In this trial, you can also remember that the radiographic progression in the group that received the biologic and methotrexate out of the gate seemed to be a little better throughout this study, which is now at more than 6 years. I just want to mention another trial just because it's interesting, and that was a Japanese trial looking at etanercept and the ability to discontinue it. I didn't make a slide of this, but really the conclusion is the same, and that is that RA patients who achieve remission after receiving etanercept as a first biologic in the very early stages of RA were able to discontinue the medication after a certain interval. And actually, in this particular trial, if they flared, the etanercept was restarted with some success of control. So I really want to sort of mention, just in conclusion, that this is a concept that deserves further study. I think it's very interesting. I think it may be a way to really reduce the costs of therapy, at least in some patients, and it will be very interesting to see what you think of these concepts moving forward. Well, I want to move on to more traditional TNF inhibitor issues, particularly safety issues. I've listed in this slide what I'm going to cover, and that is TNF inhibitors and malignancy, TNF inhibitors and mortality, and TNF inhibitors and immunizations, with the conclusions there for you. I'm really not trying to overwhelm you with new data, but I think studies that are carefully done, particularly from large registries, give us an opportunity to make sure that there are no new signals, make sure that real-life patients are being followed. And remember, these registries probably include patients who would not have qualified for studies either because they didn't have enough disease or they had too much comorbidity. So these large registries tend to give us large data from which I think we can begin to make some very interesting conclusions. So the first is this concept of TNF inhibitors and malignancy. This has, as you know, been oft studied by our European colleagues, and there is a large American registry also looking at these. The first trial that I am presenting to you on a slide at least looked at the Danish Dambio registry, which was crossed very interestingly with our National Cancer Registry, giving us more than 5,000 patients on a TNF inhibitor over 23,000 plus person years. So a large group of patients carefully studied, and we've looked at these patients previously, but not for cancers. they reported no overall or specific elevation of cancer risk over 9 years of follow-up. So reassurance to us all. The next trial was from the French group, who did a systematic review of their registry, but also included a systemic review of other large registries and performed a meta-analysis. They found that a pooled risk of malignancy was 0.94, with fairly close confidence intervals if you look at that. And the conclusion here again was that there seemed to be no overall risk of solid tumors, but there was an increased risk of skin cancer in this trial. Non-melanoma skin cancer presented a risk of 1.45. A melanoma risk was 1.7. The confidence intervals, the 95% confidence intervals, were relatively close. So this meta-analysis, again, gives us some reassurance with regards to solid tumors, but questions regarding skin cancers. I think that skin cancer question will be better answered by longer studies with more patients, but I think that sort of remains as a potential risk and one that we may have to deal with for our patients here in the United States. My next slide sort of moves us off malignancy and to mortality. A very nice trial from the Swedish group discussing mortality using the TNF inhibitors. This was not really looking at death causes, but whether or not there was a difference between the TNF inhibitors with regards to mortality. And the conclusion is obvious, I think, to most of us, and thankfully, that there was no overall statistically significant difference in mortality between the three TNF drugs studied in this Swedish registry. And they include etanercept, infliximab, and adalimumab, as you would expect. Well, just a brief comment about vaccinations and TNF inhibitors. A nice trial looked at rituximab and methotrexate versus the TNF inhibitors and methotrexate with regards to the ability to give influenza vaccines, and another trial looked at rituximab and methotrexate versus TNF blockers with regards to pneumococcal vaccines. The first trial I have presented on a slide is the pneumococcal vaccination data. 294 patients listed for you there on various combinations. The conclusion of the slide, I think, again, perhaps gives us reassurance, and that is that the TNF inhibitors in this study were not associated with impaired antibody responses, although rituximab and methotrexate, both separately and together, were. So I think we've learned that some patients, at least, can receive influenza vaccines with a positive response. And again, the next slide suggests that our patients receiving TNF inhibitors can receive pneumococcal and influenza vaccines, resulting in seroconversion and co-stimulation and some ability to respond to the antigens despite the subtle but specific inhibition of the immune system. In the influenza trial, they used vaccines that are listed for you. These are similar to what we had in the United States, although not exactly the same, according to my infectious disease colleagues. Well, the other category I want to mention to you is the TNF switching category. There are a various number of small trials that have suggested that TNF switching may be okay, may not be necessary, that mechanism of action should matter. And I listed just a couple of studies for you here so that you could get a feel for what the latest observations include. The first study is from, interestingly, again, the Swedish group, although you might not know that from the first author. And in this trial, there was clearly a benefit from switching TNF inhibitors, particularly when a monoclonal was switched to etanercept. So I think this is important at two levels. The first is we can switch TNF inhibitors and pick up some efficacy. The order of that has never made particular sense or has been random. This study, which really looks at 850 patients, I mean, it's a very large trial over 6 months, clearly concluded that those patients who switched for loss of efficacy from a monoclonal to etanercept did better than those switched to yet another monoclonal antibody. Interesting data, worth discussing, and it'll be very, I think, not just interesting, but it'll be fascinating to see whether or not these conclusions hold up over long periods of time. The next study I listed for you had to do with switching, this time in primary versus secondary non-responders, and I won't define that for you because I think it's obvious. This study suggested that the initial response to the TNF inhibitors is high, but many patients discontinue because of secondary failure. And it's interesting in Europe that the NICE guidelines do not recommend TNF switching. After failing for any reason, they're supposed to go on to rituximab. Because of the data here, where successful treatment was fairly common, if the reason for discontinuation was secondary, and then the response to the TNF was pretty good, as high as 75% responding after secondary failure. Again, a fairly large trial of 297 patients, giving us, I think, a very interesting conclusion. Again, these data need to be verified over time and in larger numbers of patients, but I think there is at least now some semblance of what to do with regards to TNF switching, although no large group has really produced an algorithm that would allow us to really know what the best thing to do after a TNF failure might be. Well, my last slide had to do with 4 interesting reports that I can handle in a minute. There was yet another report about new onset of uveitis under TNF therapy. These were not necessarily patients with spondyloarthropathies or diseases that are necessarily associated with uveitis, with the suspicion being, in conclusion, that there's something about TNF inhibitors in some patients that might result in inflammatory eye disease. A couple of trials, I've listed one for you, looking at susceptibility genes. This particular trial was very nice and identified, somewhat accidentally, an association between one gene piece and another with regards to TNF therapy response. So using here genomics to determine or predict response to TNF inhibitors. I think this is our future. There were a number of studies looking at other variables with regards to TNF inhibitors in rheumatoid arthritis and genomics and proteomics. And I think we're getting closer, although probably not close enough, to having those areas really help us with specific patients. The third slide I've listed here is just another trial looking at TNF inhibitor therapy in serious infections, suggesting that serious infections are slightly increased with our TNF inhibitors and that extra vigilance is necessary. And the last slide last point on my TNF inhibitor interest and report slide has to do with this trial from Sweden, which, just as we were getting enthusiastic about responses, suggested that the sustained remission in TNF-treated patients is terribly low. I'm telling you, on first, second, third inhibitor, it was only 8%. Less than that could sustain a remission. So just when you thought we were doing really well, there are some large study groups where it is not common to achieve remission, where remissions are not just hard to achieve but hard to maintain. And so we will just use this to remind us about our world and the reality that rheumatoid arthritis patients present to us. So really, that's my update regarding efficacy and safety in the TNF inhibitors. Some very interesting conceptual and specific reports, and I have used up my time and want to thank you for your attention, and I hope to talk to you again.